So, hello everyone. I'm Tehila. I'm the CEO and co-founder of Biond Biologics. So, we are doing oncology. So, I think this is the only presentation today that will talk about oncology and biotech. So, you can see the 4 circles. Each and every circle in this slide, it's a different program that we are developing. So Biond is a company that we founded 8 years ago. It's all about developing novel life-changing therapies for cancer. And whatever we are doing is based on our own innovative research. So we did not license anything from university or hospital. We found out that our scientists are capable enough to have very good innovation in-house, which make our life very, very easy because we don't have to do any kind of university tech transfer or whatever. So we are doing everything in-house. Great, thank you. So we are working for 8 years. We are already 40 people. Most of us are scientists. We already have 1 clinical program together with Sanofi, a partnership, very successful one. I'll tell you more about it. And we also launching our next clinical program into the clinic in less than a month. And we are doing 2 things in parallel. First, we are learning immune evasion mechanisms, so the relationship between a tumor and the immune system. And after we learn it, study it, validate the mode of action, only then we are developing the drug candidate. But we are doing it in parallel. Because we want that each and every innovation that we discover will reach the clinic as fast as we can. And it usually takes us less than 5 years. So between 4 and 5 years from the minute that we have the idea till the first patient that is administered with the drug. And for us, it's very important to do it as fast as we can, but as also professional as we can. So we try to have all our research, program, clinical study, regulation in a very high and professional way so we can work together and collaborate with pharma when we want it. So this is one thing that we are doing, but we're also developing a transformative platform for delivery of antibodies into cells, and this is what I'll tell you more today. So in about 3 years ago, we did a licensing deal with Sanofi. Our first program arrived to the clinical stage. It was a very nice and lucrative partnership because in this way we can really have a nice upfront payment that we can give back to our investors, but we also took some of the money in order to develop our next program. When we had this company, thought about it, the vision of the company is really to have a company to last. We didn't want to have an exit company. We didn't want to have one idea, develop it, and after a few years to sell it. We want to keep all the expertise in the company in order that we can really have every few years new program, new drug candidate into the clinic. And this is what we did. And so when Sanofi were interested in our first program, we told them that we are not interested in having an M&A deal. We want to do some licensing deal, but in a way that we can keep the science and all the rationale in-house, means that we insisted that we will do the clinical study. So I'm happy to say that Sanofi were very flexible, and they let us do the phase 1. They paid for it, but we did it. And so it was a very successful trial. We did a dose escalation over 3 years, and we just finished it now. And I can say that it was very, very good collaboration. And we're gonna start together with Sanofi, the phase 2, or what they call the dose optimization. They already started. I cannot say much about the result of the phase 1 because it's still a secret, but we're going to publish it together with Sanofi in the next ASCO, and I can say that all the thesis, all our thought, and all our preclinical assumption were proven to be true in the clinical study, and this is the reason that Sanofi decided to go for a very broad phase 2. They already started in the US. It's going to be more than 60 different sites in the US, in Europe, and in Israel. So this is the people. As you see, all of them are Israeli. We want to keep the company Israeli. We want to stay here. We have a vision to be the next Celgene, and maybe one day next Teva, hopefully. And we are growing small. We are still small, but we are growing. And we have this vision to bring every 2 years a new compound into the clinic. And we have a lot of people abroad that helping us, all the big names in the big pharma, like in the BMS, Roche, Sanofi, and more. And this is what we are doing. So we are all about what we call biologics. And we love playing with antibodies. So in the left, you can see the immuno-oncology program that we are having. So we're having antibodies that block the signaling between a receptor and a ligand. We also developing small antibody VHH that are doing other things. For example, this program that we are having, the upper one that's called Biond 67 anti-CD28 target. So it's a small antibody that actually binds a specific sequence in the extracellular portion of CD28 and keep it from cleavage, because we found out that when we keep CD28 intact in T cells, we actually have very nice activation. But today I'll tell you about something else. I'm going to tell you about how we internalizing antibodies into cells. Okay, so I'll skip all this. This is our clinical studies, and this is the INSPIRE. So, because we were worried that we won't have enough immuno-oncology target to have every 2 years a new program into the clinic, we want to come up with a technology that will allow us to bring more and more candidates. And because we are working with antibodies, we came up with this technology. And what we are doing, we are taking advantage of a chemical modification that make a protein to be very positively charged. So when a protein is very positively charged, actually you can overcome all the challenges of the intracellular delivery. First, when you have this, the cell membrane actually engulfs this protein and internalize into the cell. When it goes into the endosome, because of the high positivity, the endosome just collapses, and all its content is going into the cytoplasm. So if you transfer something like that, you can actually transfer any kind of antibody or protein that you want. So we're having this HSA, human serum albumin. We introduce chemical modification that make it very positively charged. Then we have a short peptide, and this peptide can be actually bind to any kind of antibody that we want. And we are using VHH, small antibodies, and we can design those antibodies to bind and target intracellular proteins. So this is an example. So we are taking this VHH of antivimentin, that is it's a protein of a cytoskeleton. And when we introduce this carrier together with antivimentin, you can see that the cell actually take it inside very elegantly. And you can see that all the cytoskeleton in these cells are being bound with this antibody. So we were very happy. Actually, it took us 7 years to arrive to this stage. And after 7 years, we said, okay, we have this technology. Let's see what happened in animals. And when we did it, something really bad happened, because the positive charge make this protein to be very sticky. And it got anywhere, but not in the tumor like we want. So our chemists did something really elegant. They actually put negatively charged on top of the positive charge transiently. So when there is a change in pH, those negatively charged are being removed, and all this can go into the tumor, and that's what really happened. We got very nice PK, very nice biodistribution. You can see here in red the antibody that got exactly into the tumor cells and only to the tumor cells, and not to the liver and not to the kidney. And you can see that when we inject it into animals that have tumor, it's actually distributed very nicely and penetrates for all the layers of this tumor. And now to the drug candidate, we decided that we want to actually block signaling pathway inside the cell. And we decided to go to the RAS and RAF pathway. So you probably know, the people that now doing here that may do oncology, that the most problematic mutation is the KRAS and the BRAF. And today there are small molecules that actually attack it, but it's limited because there is high toxicity, because these small molecules go into all cells, also healthy cells, and also there is involvement of resistance. Means that when you have this molecule, the therapy, it attacked a specific mutation, and after some time, the cancer cell come with a new mutation and a new mutation, and after a very short time of therapy, some of the patients actually have a more aggressive tumor. So we said that if we can design an antibody that block all the RAS, means all the mutation, but also the KRAS, the NRAS, the HRAS. So in one time, we can actually treat all the cells inside the tumor. And we did that. So we designed a specific, what we called anti-pan-RAS. And it goes directly into the cells. And here you can see in vitro that when it goes into the cell, all the cells are dying. You can see that it happens through a very specific blocking of the pathway, because here you can see that we actually diminish the phosphorylation of ERK in this pathway downstream of the RAS. And here you can see the animal data. So we injected into mice, we injected in very high concentration, and we saw no toxicity. Means that although we are using an antibody for the wild type, RAS or RAF, we are getting no toxicity because it goes directly into the tumor. And here you can see the tumor growth inhibition very nicely. This is with the RAF, and this is with the RAS. So it's the first time ever that a company was able to internalize a protein antibody into cells, specifically into cancer cells, block a specific signaling pathway inside the cell, which actually generate anti-tumor response. So we are not giving any any drug, any chemical or any chemotherapy or ADC. The only thing that we are doing, we are blocking the problematic pathway that actually generating the cancer. So what we are trying to do inside the cell, it's what the PD-1 therapy or all the biologics did to cancer outside the cell. So actually, we're going to use this Inspire technology in order to have our new coming pipeline for the company. And our first drug out of this Inspire will come in 5 years. We have another one in immuno-oncology that is now, another one in 2 years. So in total, after 8 years working and generating in this company, we are happy to say that we gave ourselves a goal to every 2-3 years come with a new drug to the clinic, and this is what's happening. Thank you.